Good morning, Tuesday morning. Good morning. Isn't that beautiful? Morning, Francis. You be blast to the waterfall, buddy, before I get on and get moving. So, good morning. It's Tuesday morning and it is meant in Scotland here in the United Kingdom. It's Mental Health Week, which was running from yesterday through to Friday, and I'm putting up some vlogs about some prevalent mental health issues that societally we are experiencing. So I put up for today, A, yesterday was anxiety, and B, I've put up as borderline personality disorder, BPS, which is not an easy thing to talk about, borderline personality disorder. Okay, so borderline personality disorder, if you were looking at a client or indeed labelling or attempting to diagnose, it would be emotional dysregulation, avoidant attachments, people with self-harming issues, and that was one of the reasons why I chose to talk about borderline, because of the amount of self-harming and the inability for self-soothing, and there's a lot of reactive personality types amongst our young, of which we work with, that have morning Harvey, how are you? So okay, borderline. So to talk about borderline personality disorder or post-traumatic stress disorder or any of the above, there are threads of similarity which runs through all of these experiences. And in order to work with that, we go back to what we spoke about yesterday, which is trauma, attunement and attachment. So traumatise children, and you know, Scotland's jumped all over it. The ACE movement, it's making a lot of people a lot of money, and it's giving a lot of people a lot of credibility right now. They're jumping all over adverse childhood experiences. Now, if we're looking at borderline personality disorder, you would ask a question: was it diagnosed through a DSM-4 or indeed a DSM-5? If we look at the differences in those, we look at the type of questions that we're starting to ask. And my question has always been, are we asking the correct questions? Are we equipped enough to work with and regulate the avoidant attachment styles in the young people and indeed adults that we're working with? But we have to really start, I feel, again, sorry I never said this at the beginning, this is my opinion, this is the lens of which I look at reality through. I am willing to be wrong, or I am willing to look at your point of view also. I would always encourage you to do your own research and to look into things more deeper yourself. But for me personally, everything that I work with comes back to one thing, which is trauma. Now, trauma which has happened pre-age 7 years of old is dominant, and that may look like sexual molestation, childhood rape, splitting up of a family, divorce, splitting, fighting, and you know, and I think it was a DSM-4. You know, one of the questions they would ask was anybody in the house using drugs or alcohol? And I smirked at that because I think it's so basic. But, you know, we're looking at children that have been brought up with chronic or habitual drug or alcohol users, where there's been violence, where there's been domestic violence, where there's been no emotional regularity from the caregivers to the children. So for me, the place to start is great to look at. People don't remember. This is Freudian. Freud, that was deemed a madman, who eventually his theories start to become recognised, would have said that people do not remember, they reenact. And those that are, how they're perceiving their environment, those that are in destructive cycles of behaviour are not, how they're perceiving their environment is not through an objective remembering, it's through a reenacting of the trauma which has occurred to them earlier on in their development. So the trauma, I spoke about it before, repetition compulsion disorder and trauma reenacting. That's great stuff to look up and read and educate yourself on. But one of the greatest traumas, I feel, that, none of all these that I've mentioned are not important, they're very important, but the lack of attachment and attunement. When a caregiver is unable to attach and attune effectively to a child, it leaves a child traumatised because it doesn't give any mirroring or any assimilation to how the child would get a felt sense of self, okay? Now, I'm using that word self because self is not really a word that gets brought up in DSM-4, DSM-5 or indeed psychiatry, but the personality disorders that we are looking at, be that post-traumatic stress disorder, borderline personality disorder, narcissistic personality disorder, and we start to label people with these personality disorders, and then what we do is we medicate these personality disorders, and the medication that we're using for these personality disorders are basically working on the dopaminergic system, the dopamine system of the brain, okay? Then they come into therapy or see a psychologist or psychiatry, and they're not able to do any work on the original trauma because they're medicated full of drugs that are working on the dopaminergic system of the brain. So it seems kind of irresponsible to be managing these behaviours in such a way. However, do we have the resources to manage that? Do we have effective therapists that are not traumatised themselves through years of vicarious trauma, of working with the level of abuse that they see? And that opens up a whole other line of questions. So borderline personality disorder was what I started with today because it began with a B. Now, if we look at, what popped into my mind there was, if we're looking or we're working with a client who's borderline, and they're bringing up, and we're expecting to be working with them cognitively, because there's this thing called cognitive behavioural therapy, which works with singular trauma rather than complex trauma. And as I said, most traumas are interwoven with one another. But if, for an example, the left brain's your lateral brain, your right brain is your creative brain, right? And your left brain, that's right to you, but left brain and right brain. So your left brain's like your lateral, logical type of brain. That would be where cognitive behavioural therapy would work very well on that part of the brain. But if you've been traumatised in a complex series of traumas in your childhood, and you look at the brain images of traumatised individuals, and you're looking at them under an fMRI scan, and you show them a particular threat, or the sound of a particular threat, or whatever, it would normally be the whole brain that attempts to regulate that experience. But what happens in people that have been deeply traumatised is there's almost a closing off in the left and the logical brain, and the lateral brain, there's like a closing off, and it throws it into the right brain in order to attempt to process it. And then you're in a therapy room with somebody that's doing cognitive behavioural therapy that's working on your logical brain, but it's your creative right-hand side of the brain that's attempting to assimilate the information that the previous trauma that you're experiencing has come up for you. So what that tells us is the client doesn't have an issue with the past. The client has an issue with being with the issue in the present. It doesn't have a construct. The brain doesn't have a construct in order to be with the issue in the present. In 2012, I did a year of play and art therapy with vulnerable and traumatised children, and that work was extremely valuable in my career. I would say it's certainly opened up many different ways in order for me to... Hi there, I'm back. I was just reconnecting there, coming through the woods. The majority of individuals is complex trauma we're working with, and an enmeshment and an entanglement of many different types of trauma. So, how do we look at that? Okay, so for most people that have got personality disorders that have been labelled with, they've got a feeling of mistrust, they've got a feeling of not belonging, and a feeling of not being able to connect, an inability to regulate emotions effectively, explosive emotional disorders, places where there's slight paranoia, and how they're viewing their sensory world and interpreting that in a somatic experience could be completely way off, which then throws us into body dysmorphia and how we view ourselves and our external world, and also how we view cues, external cues, from other external stimuli, i.e. people, caregivers, therapists, school teachers, even if you've ended up in prison. And when you look at some of these ACE studies that are going about, high percentage of people that have ended up in our prison system that are blocking up and choking up our mental health systems, it's all stemming back to childhood trauma. So childhood trauma is a place where there's a massive disconnection from the self. So if you've lived dissociated from a self for so long, the journey back would be a journey back to self, to experiencing what makes you tick, what once you've done work with a client, once you've done work with a client that's allowing them to regulate more effectively. And the majority of people that end up in therapy rooms aren't able to make eye contact, they're not able to sit still, they're not able to concentrate, they're not able to be, as I've said, present with themselves. It's not so much they have an issue with the past, of which the past is always present. They have an issue with being in the present because of how the brain is assimilating the information that's being provided to us. So, through effective therapy, and I say that very candidly, effective therapy, when you're working and seeing 6 clients, 7 clients a day, one after the other, it's all about collecting data in order to get the funding to keep the programme running. It becomes a bit of a monster wheel, whereas if you're lucky enough to be in an organisation where you see less clients more frequently, there makes a difference in the way that we're able to regulate and work with that client to find coping strategies that work for them rather than something that's just come out of a textbook, because each individual client and complex needs is completely different. So I'm back banging on about trauma and how trauma is that disconnection from self, disconnection from something other than the personality that you've created in order to manage this environment, which then ends up running out of fuel in a lot of ways, which ends up getting fueled by running in sort of certain types of emotions rather than feelings. And that's very, very important right now. Don't get mixed up between emotions and feelings. And oops, I'm making a mess of this morning with the phone. So we're looking at mental health, we're starting to talk about mental health, And it's not to say that if you experience any of these behaviours, like you don't trust someone, or you find it very difficult to connect to others, or, you know, it's like when you're in therapy, it's like, who was that person that made you feel special? Now, a lot of people don't have that person. I can look back and say that it was my grandfather, right? So when I'm looking at working on any form of attachment issues that I may have or experience, okay, I can then bring in a safe, kind, smiling, even talking about him now is giving me a warm feeling, right? I can bring that in. So any work I'm able to do, there was always that one person that made me feel safe, made me feel valuable, made me feel worthwhile, etc, 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 okay? Whereas for so many people, they don't have that. They don't have any point of reference where there's any safety whatsoever. And they've never been taught how to be self-reliant or resilient. And then what we see showing up in the therapy rooms is people that have been labelled with a myriad of mental health diagnosis. And a lot, I'm not saying always, but a lot of people get misdiagnosed and then get misdiagnosed appropriate and effective pharmacology way of looking at their issue. Okay? Now, when we're looking at issues such as suicide, self-harm, it's not always the case, but it's a high percentage. It's like 70% of people that have committed suicide, self-harming, abusive, destructive, violent relationships. There's been sexual abuse in the history, sexual molestation in the history. As I said, it's not always the case, but it's a high percentage of the case. So the self that was traumatised as a child through that negative experience has had to dissociate to an extent in order to manage and navigate their environment, to make them feel that there's any form of control or indeed safety in it. Now that's just a personality which has been developed. It's no longer serving them, and they're coming through and they're looking for effective therapy. So if I'm speaking to therapists here, cognitive behavioural therapy is not the way that we work. You know, DBT is some kind of schema therapy. I have some success with that. But certainly, once we've got our clients to a place that's able to emotionally regulate somewhat better than they were before they started, it's looking and working with these traumas in a far more creative way. And certainly, medication, I am not saying I am anti-pharmaceuticals, but I don't project that. As I say to people, if I have a motorcycle accident or a road accident, I don't want somebody coming along and doing CBT with me, putting lavender oil on my wounds and throwing Reiki symbols all over me. I want an injection of morphine, like an epidural right into my spine, and I won't rush to hospital, and I want surgical and pharmaceutical intervention. Sometimes that is the only option. But if we're only treating the symptom and not the cause, what we find is people start to become dependent on the pharmacology in order for them to navigate their own world. What I'm suggesting for people to take personal responsibility, if you're watching this and you've experienced trauma, is start to work with your deepest wounds, your core wounds that are probably very traumatic, that's caused a lot of psychological splitting and caused your mind to become very black and white. And find a very effective therapist and start to work through those earliest of development traumas. So, Mental Health Week, we are talking about tomorrow codependency, and I'm just out on my walk with my wee dog. Look at that. That's how you take responsibility for your mental health. Or rather, that's how I take responsibility for my mental health. It's very easy to become tired. It's very easy to forget about ourselves in whatever profession it is that we're doing. And yes, we do need to take slightly more responsibility for ourselves, and that means we've got to work at it. You know, as I say to people, those guys that, well, there's a lot of guys that come down and they're coming and they swim in the River Clyde in the mornings, and they're all got phenomenal physiques. They didn't just wake up with that. You know, they didn't wake up with that phenomenal physique. They actually have to go out and they have to work it. One of the chaps was coming in the Clyde this morning. I left the house just at 6 o'clock this morning, and it's raining outside and it's nice and cosy in my bed, and yeah, I could have just stayed in my bed for another hour or so and then made my way down to the Clyde at 8 o'clock. But these are the kind of habits that we have to start to, it's not just one habit, we have to start to formulate many new habits of behaviour, which is a way of regulating and soothing the self, rather than using destructive behaviours to soothe the self as coping mechanisms, be that violence, be that alcohol. You know, working in residential rehab for a long time and working with clients that have become sober, one of the dual diagnoses that's very prevalent in recovery is that you see borderline personality traits, borderline personality disorder traits start to come to the surface, because these feelings were probably starting to come to the surface very early on in adolescence or early adulthood, and the organism had no other way of managing these raw emotions and feelings but was to reach out for alcohol or drugs. So in a large percentage of people that I personally worked with, that when people are entering into a journey of recovery and sobriety, as the homeostasis attempts to regulate, what we see as a dual diagnosis of alcoholism or indeed personality disorders. Whoop. Morning, Lynn. My man's best friend, hi. Out with the dog, Harvey. So, yeah, be that, you know, and we know how powerful exercise is, and we know how powerful exercise is. There's lots and lots of things. I absolutely encourage you, if you're struggling in any kind of way, to reach out, ask for help. There's myriads of mental health organisations on the go right now. There's many things that you can do personally. Joining cycling clubs, joining gyms, joining boxing clubs, just going out a walk. You know, I do this every morning. You want to go a walk? Give us a holler. I leave the house at 6 o'clock. It's 8 miles, takes me 2 hours. Give me a shout. We can walk 2 metres apart. It's cool. You know, there's people out there that are absolutely in service. So, one of the difficulties, the very first difficulty, the difficulty is the journey of 1,000 miles starts with the first step. It's taking that first step. The hardest thing is actually recognising that we're struggling with some kind of mental illness. And for me, getting in the Clyde, getting in the rivers, I was introduced to that about a year or so ago. I went down to see a guy in London last February 2019 that would have been. And I did it most days for a year. And when you're sitting in that cold water exposure, it brings you straight into being present. It brings you right into presence. It brings you right into being present, because you can't think about anything else other than the staying alive in the cold water, and all your other issues just... Oh. Thanks. You're a nasty wee man. Terrible wee guy. That little dog wasn't doing anything and Ralph just became a Doberman. Right, so borderline personality disorder, many different labels out there. I would encourage you to look at traumatic issues from the past, look at more effective ways of self-soothing and self-regulating, and to form good attachments and attunements with people that you are working with. If you don't dock with your therapist, get another therapist. If you don't dock with the organisation, if you're not completely aligned with the organisation and the way that they are working, find yourself another one. Find yourself another one. It might take you 10 attempts to find something that's going to work for you, but I would recommend and encourage you to do that and start to meet them halfway, take some personal accountability for where you're at, no matter how difficult that might be. I do understand that when we're in a place of self-loathing and self-isolation, it's extremely difficult to put our head above the parapet, and that's not going to, in the long term, going to be helpful or effective. So have a great day, wish you all the best, and I hope that's been helpful. Have a good one.